Welcome back, everyone. Ready for another deep dive?
Always.
Today, we're going to tackle the art of patient interviewing and examination, specifically in respiratory care.
Oh, that's a good one.
Yeah, we're digging into this really interesting lesson handout, the one that focuses on those initial steps, like the first interactions with a patient.
Right. These are so important.
Because they can really, I think, make or break the whole experience for the patient.
Yeah, for sure.
Imagine this. You have a patient, they come in, and their main complaint is they're having trouble breathing.
Mm-hmm.
Sounds pretty straightforward.
Yeah.
But how do you, as the respiratory therapist, really get to the bottom of what's going on?
That's the key question.
That's what we're going to try to unravel today.
It's about more than just, collecting data. It's about connecting with the patient, understanding their story.
Absolutely.
We're going to uncover how, some of those questions that seem really simple actually be really powerful in revealing a patient's, true respiratory health.
So true. So let's jump right in. Our source material highlights these two pillars of understanding a patient.
Okay.
The medical history
Mm-hmm.
and then the physical examination.
Makes sense.
Now, I know it might sound super basic,
Yeah.
but why is that medical history so crucial? What makes it like the foundation?
Think of it like, like building a house.
Right.
Right? You wouldn't start with the roof.
Right.
The medical history is like that solid foundation.
Yeah.
And our source material lays out 10 essential components of a comprehensive history.
Okay.
But the one that I think often gets overlooked is that, the source and reliability of the information.
Oh, interesting.
So are we getting this information directly from the patient?
Right.
Is it coming from a family member?
Mm-hmm.
Maybe we're pulling it from, some old records.
Right.
Understanding the context of where that information is coming from is critical for accurate assessment.
That makes total sense. We can't just take everything at face value.
Right.
Especially in respiratory care.
Especially in respiratory.
Because symptoms, they can be so subjective.
They can be, yeah.
Speaking of trust and context, our source, they really emphasize building rapport from the get-go.
Right.
How do those first interactions impact the information that we're getting from the patient?
Well, you got to imagine you're the patient, right?
Yeah.
You're feeling probably pretty vulnerable.
Yeah.
Maybe even scared.
Right.
And if you're not comfortable with the person who's asking you all these questions,
Right.
you might hold back important details,
Absolutely.
So projecting interest, establishing that professional role, respecting the patient's beliefs,
Yeah.
making sure they know everything's confidential.
Right.
Those things are so critical.
Right.
It builds that trust.
So
So they're going to communicate openly and honestly.
it's like you're building that safe space
Exactly.
for them to share their story, even the parts that might be, uncomfortable to talk about. And that leads us to the art of asking questions.
Yes.
Our source material outlines 3 types of questions: open-ended, closed,
Okay.
and direct.
Right.
And it's fascinating to me how each one is like a different tool in your toolbox.
Absolutely. Each one's going to give you different information.
Yeah.
Open-ended questions like, can you tell me more about your difficulty breathing?
Mm-hmm.
Those invite the patient to elaborate,
Right.
give you some context, reveal details that maybe they wouldn't have thought to mention otherwise.
Right.
It's like opening a door and seeing where the conversation leads.
I love that. That's a great analogy. But then we have closed questions.
Yeah.
Like, when did the shortness of breath begin? Or do you experience chest pain when you cough?
Right.
And those seem much more focused.
They are, yeah.
Like they're helping us pinpoint specific details.
Exactly. Closed questions, perfect for figuring out timelines, clarifying symptoms, confirming or ruling out certain possibilities. It's like you're using a magnifying glass.
Ooh, I like that.
You're zooming in on the finer points.
Yeah, okay.
But then you've got those direct questions.
Oh, yeah.
Like, why haven't you been using your inhaler as prescribed?
Right.
Now, those can be kind of tricky, can't they?
They can be because those require, I feel like, a really strong sense of rapport.
Definitely.
Because you're kind of delving into potentially sensitive territory.
You are.
And if the patient feels judged,
Yeah.
they might not be honest with their answers.
Right, exactly.
Our source material also highlights, the importance of avoiding leading questions.
Oh, yeah. That's a big one.
Because those can kind of like inadvertently influence how the patient responds.
Exactly. You want to be neutral.
Yes.
You want their genuine experience.
Right.
Not like a response that's shaped by what we're expecting to hear.
Right, exactly.
So imagine you ask, your breathing's much better today, isn't it?
Right.
That little suggestion
Yeah.
might make the patient a little hesitant to mention if they're still having difficulties.
Totally. It's like we're detectives, right? We're gathering evidence to try to solve this mystery of their respiratory symptoms.
Love it.
And as detectives, we need the right knowledge
We do.
to guide our investigation.
Absolutely.
The source points out how crucial, a good understanding of cardiopulmonary pathophysiology is in this whole process.
Couldn't agree more.
Yeah.
If we don't understand how the respiratory system works,
Right.
how can we even interpret what the patient's telling us?
Right. You can't.
Or know which questions to ask.
Right.
It's like trying to navigate a maze without a map.
So true. We need that foundational knowledge to even begin making sense of the clues.
Exactly.
Now let's shift gears a little bit.
Okay.
Talk about some of the common cardiopulmonary symptoms that we encounter.
Okay.
Our source material kind of jumps right into dyspnea
Yeah.
or shortness of breath.
Yeah.
It's like, it's such a common complaint.
It is.
But it seems like there's still a lot that, we don't fully understand about its mechanisms.
That's right. The source explains that we haven't totally figured out exactly how dyspnea works, but we do know it often comes down to the patient feeling like their work of breathing is too much,
Mm-hmm.
like their body's having to work too hard just to breathe.
Right.
And it's not efficient.
It's like that feeling of air hunger.
Yeah.
Like no matter how hard you try,
Yeah.
you just can't get enough air in.
Exactly. Yeah.
And our source material introduces these like different grades of dyspnea.
All right.
From grade 1 to grade 5, which help us kind of assess its severity, right?
Yeah.
Can you explain those a little more?
Sure. Think of it like a scale.
Okay.
And each grade shows us how much dyspnea is affecting the patient's daily life.
Okay.
So like grade 1, for example,
Mm-hmm.
that's like the normal breathlessness you might feel after climbing a flight of stairs.
Yeah.
But as the grades go up, the dyspnea becomes more limiting.
Right.
So grade 5,
Mm-hmm.
that's the most severe.
Right.
Even simple tasks like getting dressed can leave the patient gasping for air.
Wow. So those grades give us a way to measure how much it's affecting their quality of life.
Exactly.
Yeah. I remember I had this patient once who was grade 4.
Mm.
She could barely walk from her bed to the bathroom
Wow.
without feeling like she was suffocating.
Yeah.
And it really highlights how serious those higher grades are.
It's a powerful reminder that dyspnea isn't just a symptom. It's an experience that can really affect their well-being.
Absolutely. And then we've got these fascinating variations of dyspnea.
Yeah.
Orthopnea,
Mm-hmm.
platypnea,
Okay.
and tropopnea.
Yes. Each one linked to specific conditions.
Now, those are some interesting terms. Let's break them down.
All right.
Orthopnea. Mm-hmm.
That's when someone has difficulty breathing when they're lying down, right?
That's right.
I remember learning it's often seen in patients with congestive heart failure.
Exactly. And then platypnea is the opposite.
Okay.
Shortness of breath when they're upright.
Interesting.
That one's less common,
Mm-hmm.
but you might see it after someone's had a pneumonectomy.
Okay.
That's where a lung is removed.
Right.
Or in people with chronic liver disease.
Okay. And what about tropopnea?
Tropopnea.
That one always sounds like especially intriguing to me.
It is interesting. It's when lying on one side makes their breathing better.
Okay.
So it's like the body saying, hey, this position, this helps me breathe easier.
Mm-hmm.
So that can be a clue pointing towards things like CHF or a pleural effusion, where fluid builds up around the lungs.
It's amazing to me how all these different breathing patterns can give us such specific clues.
It is.
And speaking of clues,
Mm-hmm.
our source material really dives into the nuances of coughs.
And it emphasizes that a cough is way more than just a simple reflex.
It is. It's complex.
Yeah.
Deep breath,
Yeah.
lung recoil,
Wow.
expiratory muscle strength, airway resistance.
So the effectiveness of a cough can tell us a lot about what's going on.
So much, yeah.
And there's so many characteristics to consider.
Right.
Like, is it dry? Or is it loose?
Mm-hmm.
Is it productive? Non-productive?
Yep.
Acute? Chronic?
Uh-huh.
And even the timing of the cough.
Don't time me.
Like, it's a hidden language
It is.
revealing secrets about what's going on in the lungs.
Right.
And then there's sputum.
Ah, sputum.
Our source, delves into this whole fascinating vocabulary.
Oh, yeah.
Phlegm, purulent, fetid, mucoid.
All those great words.
Each term gives us another piece of the puzzle. I always thought sputum was just, kind of gross.
Yeah.
But now I realize how much it can tell us.
It can.
And don't even get me started on the color chart.
Oh, the color chart. You're right.
Right.
White or clear.
That's usually normal.
Right.
But then you get yellow, and that can indicate infection. Green might be like old secretions.
Yeah.
But if it's green and foul-smelling, think Pseudomonas. Brown could be old blood. Red is fresh blood.
Right.
And pink and frothy.
Classic pulmonary edema.
Classic, right.
Yeah.
Who knew there was so much to learn from something we usually try not to think about?
I know, right? But it's incredible. The body's always communicating with us.
Yeah.
It uses these subtle signs to signal what's happening beneath the surface.
Yeah.
And our job is to figure out how to decode those messages.
Absolutely.
We've covered a lot of ground already.
We have.
Shall we move on to another crucial piece of the puzzle, which is chest pain?
Let's do it. I'm eager to hear what our source has to say about, how to differentiate between the different types.
All right, let's dive in. Chest pain. Chest pain, one of those symptoms.
Yeah. Wow.
Yeah, it's a red flag.
Yeah, for sure.
Our source material really emphasizes how important it is to figure out the difference between the two main types, pleuritic and non-pleuritic.
Okay, so let's break those down. Pleuritic pain. That's like that sharp stabbing pain.
Right.
Usually it's on the sides or the back, and it gets worse when you take a deep breath.
It does.
I remember learning that it's often linked to issues that are directly affecting the chest cavity itself.
Exactly. Think about conditions like pleurisy.
Okay.
Where that lining of the lungs gets inflamed.
Right.
Or even pneumonia, where the air sacs themselves are affected.
Okay.
The key here is that the pain is directly related to the lungs and how they move when you breathe.
Got it. So if it's a sharp pain that makes you not want to take a deep breath, that's a clue. It could be pleuritic.
Exactly.
But what about non-pleuritic pain? How is that different?
Non-pleuritic pain, it's usually more of a dull ache or pressure.
Okay.
You usually feel it in the center of your chest, and it might kind of radiate out to other areas.
Okay.
And it doesn't really change that much with breathing.
So it's less about the lungs themselves.
Right.
And more about other structures in the chest.
Exactly. It's like the difference between a splinter and a muscle ache.
Okay.
Splinter causes that sharp, really localized pain. A muscle ache, it's more widespread, less intense.
Right.
So non-pleuritic chest pain could be a sign of, something like angina.
Okay.
Which is caused by, not enough blood flow to the heart muscle.
I see. So understanding the location, the severity, whether or not it changes with breathing.
Right.
All those things can help us narrow down the possibilities.
Easy
We're gathering these little pieces of a puzzle.
Yeah.
And each clue gets us closer to the bigger picture.
Absolutely.
Speaking of clues.
Yeah.
What about fever? Our source mentions fever as another important symptom to watch for.
Fever often means the body's fighting an infection. And remember, when your temperature goes up, your metabolism goes into overdrive.
Right.
Which means your body needs more oxygen, and it's producing more carbon dioxide.
Okay.
So that can really put a strain on the respiratory system.
Yeah.
Especially in patients who already have some lung issues.
So a fever on top of respiratory symptoms, it's like adding fuel to the fire.
It is.
It's like a sign that we need to be even more careful in our assessment.
Absolutely.
Our source also mentions swelling in the lower extremities.
Right.
Which I guess can be a sign of something more serious going on with the heart.
Yeah, swelling in the legs and ankles. Also called edema.
Okay.
That can be a sign of heart failure.
Okay.
Including a specific type called cardiopulmonary.
Pulmonary, okay.
That's where the right side of the heart is affected because of lung disease.
I see.
So you got to remember, the heart and the lungs, they work together.
Right.
So problems in one system, they can affect the other.
Right. It's like a domino effect.
It is.
It makes me realize, how important it is to look beyond just the obvious symptoms.
Right.
And consider those signs that might not seem directly related.
Yeah.
It might be telling us something really important about their overall health.
It's all connected. That's where the detective work comes in.
Oh, yeah. I love that.
Remember earlier we talked about the source material saying we got to be like detectives.
Right.
Gather evidence, piece together clues.
Yeah.
Well, now we're putting those skills to practice.
Okay, I'm ready to put on my detective hat. So let's say, a patient comes in and they're complaining of shortness of breath,
Okay.
especially when they lie down.
Mm-hmm.
They're also coughing up pink, frothy sputum.
Okay.
Where would we even start?
Well, the orthopnea and that pink, frothy sputum,
Yeah.
those are big clues,
Okay.
pointing towards pulmonary edema,
Mm-hmm.
which, remember, is that buildup of fluid in the lungs.
Right.
And this often happens because of congestive heart failure,
Okay.
where the heart isn't pumping like it should.
So the heart can't keep up with the demands of circulating blood.
Right.
And all that extra fluid ends up backing up into the lungs.
Exactly.
But what if the patient had a fever and they were coughing up thick green sputum?
Okay, well, that combination of symptoms, that would make us think more about a possible bacterial infection, like pneumonia.
Okay.
So that green sputum,
Yeah.
that tells us there are white blood cells in there,
Right.
the body's little soldiers sent to fight off that infection.
And the fever would be the body's way of,
Yeah.
creating an environment that's not very hospitable to those bacteria.
Right, exactly.
So the type of sputum, whether there's a fever or not,
Mm-hmm.
those things can help us differentiate between, like, a cardiac issue,
Right.
like heart failure, versus a respiratory infection like pneumonia.
Exactly. It's all about connecting the dots,
Yes.
looking for patterns in their history, their symptoms, what we find on the physical exam.
Right.
Like we're solving a jigsaw puzzle.
I love it.
Each piece gives us a little more of the picture.
Okay, let's try another scenario.
Okay.
What if our patient has that sharp, stabbing pleuritic chest pain?
Okay.
What conditions might we be thinking about?
Well, with pleuritic chest pain, we'd be thinking about things that cause inflammation or irritation of the pleura.
Okay.
Remember, that's that lining around the lungs.
Right.
So pleurisy, pneumonia, even something as serious as a pulmonary embolism could be on the list.
So pulmonary embolism.
Yeah.
That's when a blood clot travels to the lungs, right?
That's right.
That sounds really serious.
It is.
What clues would make us suspect something like that?
Besides the pleuritic chest pain, we'd be looking for sudden shortness of breath, a really fast heart rate,
Okay.
maybe even coughing up blood.
Okay.
That's a situation where, we got to act fast.
Wow, this is really starting to feel like a detective show.
It is.
It's not just about, identifying the symptoms.
Right.
It's about understanding why they're happening.
Right, exactly.
So if we suspect congestive heart failure, we got to figure out why the heart isn't pumping effectively.
You got it.
Yeah.
Is it a problem with the heart muscle itself?
Right.
Is there a blockage in the arteries? Or is it because of another condition like high blood pressure or lung disease?
Right. So many possibilities.
Exactly. You got to get to that root cause to figure out the right treatment plan.
And the treatment plan for something like pneumonia is going to look totally different than the treatment plan for heart failure.
Completely different.
It's fascinating how everything we've discussed, from the initial questions to those little signs that we observe, all of that ultimately guides, how we make decisions.
That's the beauty of respiratory care. It's art and science together.
Yeah.
We use our knowledge of, anatomy, physiology, pathophysiology.
Right.
Combine that with our observation skills.
Right.
Critical thinking, intuition.
Yeah.
To make, informed decisions that really impact a patient's life.
It's like we're weaving all these different threads of information together to create a tapestry that represents the patient's unique, respiratory health journey.
Love that analogy. And remember, that tapestry, it also includes the patient's perspective, their beliefs, their values, how they understand their own health.
Right.
So building rapport, making them feel safe to communicate, involving them in their own care.
Yeah.
Those are just as important as the technical stuff.
Absolutely. It's about treating the whole person, not just the disease.
Exactly.
It makes me realize that to be a good respiratory therapist, it takes more than just knowledge and skill.
Right.
It takes compassion, empathy.
Couldn't have said it better myself. But remember, the journey doesn't end with the diagnosis and the treatment plan.
Right.
It's ongoing.
Yeah.
Monitoring, adjusting the plan as needed.
Right.
Helping the patient be involved in their own care.
That's so important. Respiratory conditions, they often require long-term management.
I do.
So teaching patients about their condition, how to use their medications, the importance of lifestyle changes.
Right.
All of that's crucial for their success.
It's about being partners.
Yeah.
The patient and the clinician working together as a team to get the best possible outcome. And that teamwork, it goes beyond the individual patient too.
Oh, yeah.
We need to advocate for better access to care.
Right.
Promote lung health in our communities.
Yeah.
Raise awareness about respiratory diseases.
It's a big responsibility.
It is.
But it's also, incredibly rewarding.
It is.
Knowing that we can make a real difference in people's lives.
That's what keeps us going.
Right? It is.
It's what fuels our passion for this field.
Absolutely.
Speaking of passion, I think it's time we dive into the physical exam itself.
Okay, yes.
We've talked about how important observation is, but now it's time to put those skills into action.
I'm ready. Let's explore what our source material has to say about, the actual hands-on techniques involved in assessing a patient's respiratory health.
All right, let's get hands-on.
Okay, so let's get hands-on with the actual physical exam. Our source material starts by emphasizing just looking at the chest. What are some key things that we should be observing?
Well, you can learn a lot just by observing. First, we look at the shape of the chest. Is it symmetrical? Do we see any abnormalities, like barrel chest, which can be a sign of emphysema, or pectus excavatum, where the breastbone sinks in?
I've heard of those conditions, but can you remind me why they matter, specifically in respiratory care?
Sure. So barrel chest, for example, it develops over time as the lungs get hyperinflated, which makes it harder to exhale fully. It's like trying to blow up a balloon that's already full of air.
Right.
And then pectus excavatum, it might seem like just a cosmetic thing, but it can actually make it harder for the lungs to expand. So it's harder for the person to take a deep breath.
It's like the chest wall itself is working against the lungs.
Right.
What about scoliosis? How does that, the curvature of the spine play into respiratory health?
Scoliosis can impact lung function in a few different ways. It can restrict the amount of space that the lungs have to expand. And it can also affect, the mechanics of breathing, making it less efficient. It's like trying to inflate a balloon, but the balloon's been twisted into a weird shape.
It makes you realize how much we take normal chest movement for granted, right?
Yeah, for sure.
Our source material also mentions that we should look at the muscles that people are using to breathe.
Right.
What's the significance of that?
So think about it. When we breathe normally, we're mostly using our diaphragm, the big muscle below the lungs. But when someone's really working hard to breathe, they start using other muscles, like the ones in their neck, the sternocleidomastoids and the scalenes. Those run from the neck to the ribs.
So it's like calling in reinforcements when the main troops are struggling.
Exactly. If you see those accessory muscles working hard, that's a visual clue that the person is in respiratory distress. They might need help. We can't ignore that.
Yeah. So we've inspected the chest visually. Now our source tells us to palpate, which basically means feeling for anything unusual. So what are we assessing when we palpate?
We're gathering information about chest expansion, vocal fremitus, and subcutaneous emphysema.
Okay, I'm going to need you to break down some of those terms.
Sure.
What is vocal fremitus?
It's the vibration you feel on the chest wall when the person is talking.
Oh, okay.
We put our hands on their back and ask them to say 99, and then we feel how strong those vibrations are.
So it's like we're feeling the sound waves as they travel through the chest.
Yeah, pretty much.
What does it mean if the vibrations are different on one side than the other?
That could mean that something's blocking those sound waves. Like maybe fluid or air in the pleural space. That's the area between the lungs and the chest wall. Imagine trying to hear someone talking through a wall. It's going to sound muffled.
That makes sense. Okay, what about subcutaneous emphysema? What are we looking for there?
Subcutaneous emphysema, that's a crackling sensation you might feel under the skin. It feels kind of like bubble wrap popping.
Okay.
That means air has gotten out of the lungs, and it's trapped in the tissues under the skin.
That sounds kind of scary. When would we see that?
It can happen with a pneumothorax, which is where air leaks into that pleural space, or with certain types of lung injuries. It tells us that, something's wrong with the respiratory system. It's not intact anymore.
Okay, so we've inspected the chest, we've palpated. Now it's time for, I think, the main event.
Auscultation.
Yes, auscultation. Listening to the lungs.
With our trusty stethoscope.
Exactly. I always feel like this is where things get really exciting.
Me too. We get to hear the breath sounds, and they can tell us so much about what's going on inside. It's like listening to a symphony of the respiratory system.
I love that. Our source material talks about all the different types of breath sounds. Vesicular, bronchovesicular, and bronchial. Can you break those down for us?
Sure. Think of the respiratory system like a tree. The trachea is the trunk. The bronchi are the branches. And then the bronchioles and alveoli, those are like the tiny leaves where the gas exchange happens.
Okay, I like that.
So vesicular breath sounds are those soft, rustling sounds. We hear them over most of the lung fields. And they're created by the air moving through those tiny leaves.
So that's like the sound of air reaching the very ends of the respiratory tree?
Exactly. Then you've got bronchovesicular sounds, which are louder and a little bit higher pitched. We hear those over the larger airways, so it's like listening closer to the branches of our tree.
Okay, and what about bronchial breath sounds?
Bronchial sounds are the loudest and the highest pitched. It's like listening right over the trunk of our tree, the trachea. Now here's the thing. If we hear bronchial breath sounds in an area where we should be hearing vesicular sounds, that's a red flag.
What would that indicate?
Could mean there's consolidation in the lungs. That means that the sound is traveling more directly to the chest wall. So, for example, pneumonia. The air sacs fill up with fluid and stuff, which makes them denser. It's like the difference between listening to someone whisper in a big open room versus a small closet. The sound's much clearer and louder in that closet.
Wow, I'm really starting to understand how even small changes in breath sounds can tell us so much. What about those extra sounds, the crackles and wheezes and raunchy?
Those are called adventitious breath sounds. They're like little bonus clues.
Okay.
Each one tells us something different about what's going on in the airways.
Let's start with crackles. I've heard them described as sounding like Velcro being pulled apart. What causes that?
Crackles usually mean there's fluid in the airways.
Mm-hmm.
Could be a sign of things like pneumonia, pulmonary edema, or even fibrosis. Fibrosis is where the lung tissue gets scarred and stiff.
Okay. What about wheezes? Those are like whistling sounds.
Exactly. Wheezes mean the airways are narrowed, which is often because of bronchospasm. We see that a lot in asthma and COPD. Imagine trying to breathe through a straw that's almost completely pinched closed.
Okay, and what about raunchy?
Raunchy are those low-pitched, snorry sounds. It's like thick mucus rattling around in those larger airways.
Okay. And I remember you mentioning stridor earlier, that high-pitched crowing sound during inspiration.
Right, stridor.
Mm.
Stridor tells us there's a big obstruction in the upper airway. So like the trachea or the larynx, that's a medical emergency. You got to take care of that right away.
It really is incredible how much information we can get just by listening carefully. It's like we're learning this whole new language, the language of the respiratory system.
Exactly. A good clinician knows how to interpret all those subtle sounds and then connect them to the patient's history, their symptoms, and what else they find during the exam.
This deep dive has been amazing. We started with the art of interviewing and building that rapport with our patients. Then we dug into dyspnea and coughs and sputum and chest pain. And we even uncovered all those secrets hidden within the breath sounds.
It's been a lot of information, but I hope our listeners are walking away feeling like they've learned something.
Me too. Because knowledge is power, and the more we know about the respiratory system, the better we can be as advocates for our patients, and we can provide the best possible care.
That's right. So listeners, remember, it's not just about memorizing facts. It's about being observant, being curious, and really wanting to understand the person behind the symptoms.
And never underestimate the power of those simple observations and those simple questions. Because a change in breathing, a little cough, a subtle change in breath sounds, all those things can be crucial clues in understanding a patient's respiratory health.
Keep learning, keep asking questions, and keep listening, because in respiratory care, every breath tells a story.